We're interested in the first dose, and that first dose was 27 times higher than baseline. 27 times higher levels of testosterone than baseline is what that first dose achieved. And that is a huge spike in testosterone and partial proof that the first injection may actually be very potent at kickstarting your HPT axis back into life. So guys, I thought I'd do a video on what you need to do if your conventional PCT fails. And this is just a little idea and a delve into the science about some new methods of PCT that might start to become available for guys coming off long-term steroid abuse who cannot, for the life of them, seem to get their testosterone level above like 250, 300 nanograms per deciliter, despite doing a conventional PCT with a SERM plus HCG plus nutrition plus giving it enough time. And from guys I've worked with across the world, I can usually get them pretty close to about 70 to 75% of their pre-TRT levels, depending on how long the blast was, compounds they've used, and if they used any heavy compounds like 19-NORs. And obviously this is not a perfect science and can be complicated by a lot of things. Older guys seem to recover more slowly than younger guys, and those that have used, like I said, 19-NOR testosterone derivatives or progestins that are a lot more suppressive than non-19-NOR compounds to the HPT axis. These guys are going to have a much harder time to recover HPT axis functioning than guys who have, say, just done TRT for like 6 months and want to get off. And obviously time as well, like I said, is a huge one too. Someone who's blast and cruised for 10 years with heavy trenbolone use is going to be very different to the guy who's just done 70 milligrams of test for, like I said, 6 months and wants to restore their pre-TRT levels. Now, in most cases, the big three conventional PCT compounds usually work. That is time being number one, initial HCG stimulus, but removing that quickly as HCG itself is suppressive to the HPT axis, and then a SERM to modulate the estrogen receptors to increase testosterone. These usually work, but what happens to the guys who slip through the cracks and who can't seem to get their testosterone levels up despite doing a conventional PCT? Now, I do have some theories here about actual damage to the Leydig and Sertoli cells, like death and apoptosis. But what's interesting in a lot of these men is that Clomid or enclomiphene can boost their testosterone levels to very, very high levels, often top of the reference range. And they get significant boosts in their luteinizing hormone as well in their blood work. And I've seen this blood work in person. But the issue is, once that stimulus is pulled out, they often go right back down to hypogonadal levels of testosterone. In other words, it's almost as if the brain signaling isn't there. So once the LH is high, falsely through like enclomiphene, they produce enough testosterone and everything seems to be functioning well. But once that's taken away, their brain is not producing adequate signaling, LH, FSH, to support their natural pre-TRT or pre-cycle levels of testosterone. So in my opinion, the fact that enclomiphene can boost their LH and produce enough testosterone once they're on that is kind of proof that it's a brain signaling issue. So it's higher up in the H and the P, hypothalamus and pituitary part of their HPT axis. The testicles, once signaled and once given enough signaling, work fine. It's actually that their brain is not able to support adequate levels. So there is another option for these kind of men in the research, and that is a compound called triptorelin. Now, this is an analog of GnRH, and it acts in the same way that GnRH, gonadotropin releasing hormone, does. Now, if we actually look at the HPT axis way up in the hierarchy, in the entire HPT axis cascade, GnRH is released initially from the hypothalamus to stimulate your anterior pituitary gland to release LH and FSH. So the idea is this: if you can kickstart your HPT axis back into life with a single potent dose of GnRH, the idea is that you may be able to wake your HPT axis back up, so to speak. Now, initially, it might be confusing because if you search up triptorelin online, you get the following results. Triptorelin is a gonadotropin releasing hormone agonist that is a potent inhibitor of the synthesis of testosterone in men and estrogen in women, and is used to treat advanced prostate cancer. So a potent inhibitor of testosterone, isn't that the exact thing we're trying to avoid? Well, triptorelin is a double-edged sword in the research. Initially, in the first injection, triptorelin, like other GnRH agonists that work in a similar way as GnRH itself, initially stimulates the pituitary gland to pump out a huge amount of gonadotropins, luteinizing hormone, and follicle stimulating hormone. And this huge pulse initially leads to a big increase in testosterone levels and the production of sex hormones like testosterone and estrogen as the testicles respond in kind to the signaling. The double-edged sword bit comes in when you have the second dose and you keep continuing to administer triptorelin. With continued administration, triptorelin significantly downregulates GnRH receptors in the brain, and they get fully saturated in the pituitary gland, meaning that they are not as sensitive anymore and thus desensitized and downregulated. Now, this downregulation basically leads to a huge reduction in any production of gonadotropins, so no LH, no FSH signaling, and therefore you get basically castration levels of testosterone and sex hormones in the body. And this is why continued and long ester use use of triptorelin is actually used to treat prostate cancer in men to suppress androgens and basically keep these men at a level of 0 testosterone in their body. But there is an opportunity to try and manipulate, and the research sort of backs this up, there hasn't been much done, but try and manipulate that step 1 to kickstart your HPT axis back into life if you've been suppressed for a long period of time. In fact, it's hard to find research on this because so much of the research is actually looking at triptorelin as a androgen suppressor, and long-term triptorelin use in the research is linked obviously with outcomes in prostate cancer patients. So it's really hard to find any evidence of using it as actually a kickstarter of the HPT axis, but there is some limited evidence that the first injection is actually quite potent. According to this study, which administered patients 11.25 milligrams of triptorelin sub-Q, there was an initial increase in luteinizing hormone concentrations at week 1 after the first triptorelin injection. Specifically, the mean serum luteinizing hormone increased by 37.6% at week 1 compared to baseline. Now, obviously, from week 2 until the end of the study, LH levels were reduced as expected with the triptorelin pharmacokinetics and continued use. Now, regarding testosterone levels, they actually said in the study that in these patients, testosterone levels had a short-term flare-up, and they actually used this word. I'm not really sure how that got passed in terms of scientific jargon, but they had flare-up in the study. And looking at the graph again, you can see that flare-up by the first injection after the first week. Now, to be completely honest, in this study, testosterone levels only rose about 50 nanograms per deciliter, which, let's be honest, is going to be pretty useless if you're sitting at 200 to go to 250. It's like, what's the point in that? And you may be rightly thinking in this part of the video now, how is this going to help my 10-year Blyson Cruz-induced hypogonadism to any significant degree? Well, just wait. In this next study, where rats were given intramuscular injections of triptorelin acetate biodegradable microspheres at 0.6 milligrams per kilo every 28 days for 3 cycles, there was a huge spike in testosterone in the following fashion. So there was initial testosterone spike, as we just saw following the first injection of triptorelin. There was an initial big surge in testosterone levels, and the peak concentration of testosterone reached 22.8 nanograms per mil at 1 hour after the injection. If you look at this graph, this initial increase is consistent with an initial stimulation of the pituitary gland to produce huge amounts of LH and therefore huge amounts of testosterone once the testicles are more responsive to that. And obviously, after the initial spike, levels showed a rapid and sustained decrease, with castration level of testosterone reached within 5 days and maintained until day 28. But we're not really interested in that. We're interested in the first dose, and that first dose was 27 times higher than baseline. 27 times higher levels of testosterone than baseline is what that first dose achieved. And that is a huge spike in testosterone and partial proof that the triptorelin first injection may actually be very potent at kickstarting your HPT axis back into life. If you could manipulate the pharmacokinetics of triptorelin to just do a one-off injection, you could kickstart potentially your HPT axis back into life and force a sluggish HPT axis, which I see a lot on blood work in guys where they're not hypergonadal, they've just come off a heavy cycle or TRT, for example, and their levels are not, I'm not talking like hypergonadal levels at 50 or 100, I'm talking they're sitting annoyingly and frustratingly at anywhere from 200 to 300 nanograms per deciliter, still kind of within reference range or very bottom of reference range, but they just, for whatever reason, they can't break through the 400, 500, 600 nanograms per deciliter levels where they were naturally. These guys are sort of caught in the no man's land where it's not low enough to actually justify TRT, but it's not high enough where it's having any, benefit to their life. They're feeling tired all the time, libido's down, energy. So they're kind of caught in this like catch-22. What do? Well, the evidence is that triptorelin may force their sluggish HPT axis back into life. So it's really the idea of using that initial stimulatory first injection to induce a big increase in LH and hopefully kickstart the HPT axis back into life with, 27 times increase in testosterone levels. But the issue and the double-edged sword and why you need to be so careful with triptorelin online as well, you see this anecdotally, is the dosage. Just going too high in the dosage can lead to castration. It's a very fine line between using it to castrate yourself versus using it to kickstart yourself. And take this with a huge grain of salt, but evidence online and through the studies and the research shows that something like a 100 microgram shot of triptorelin once off may just be enough to kickstart the HPT axis. So in summary, this video was for the guys where a conventional PCT has failed, but they're not sure what to do because they're sitting at that borderline low level of testosterone. And in particular, where removing a conventional PCT cycle or SERM stimulus leads to them not being able to support that same level of gonadotropin signaling in their body. Now, for these guys, guys, it may be an option. Of course, the science is limited and there's barely any evidence to support this. You know, it is still very, very theoretical at this point and experimental, but I do think that some of the most interesting aspects of TRT and HPT exercise and science in general, some, you know, fantastic developments come through experimental theories, and this is potentially something where you could manipulate the pharmacokinetics to increase your testosterone if you're really struggling coming off PCT. And then a lot of guys I work with, they really struggle when they come off heavy 19-nor use, heavy blast and screw cycles for, you know, many years. Their HPT axis is damaged, but in particular, the hypothalamus and the pituitary gland part of the HPT axis is damaged, because enclomiphene, like I said earlier in this video, can get them to, you know, 800 nanograms per deciliter levels with high LH. But the issue is once that's removed, their body, for whatever reason, just can't keep up that stimulus. This may be an option for those guys. So for me to have men out there complaining to their doctor of low borderline testosterone levels, but their doctor saying, well, I can't really do anything because you're not technically, clinically, you know, low. Those guys are so frustrated, and it's so frustrating for those guys, and often why they come to me to get help, because you're sitting at like 350, you're not clinically low enough to get TRT, but you know, you have all the symptoms, you're tired all the time, and you're not getting the help. This video is for you guys. And that's unacceptable for me to have you guys like that. So this is why I try and get all this information out there, so you can just try and learn as much as you can about, you know, all of this fitness industry world. As always, thank you so much for the support, guys, and I will see you in the next video.